Very good evening to all my dear friends who have joined here through this wonderful platform. So today we are going to have an extraordinary continuation of Grey's Anatomy 2.0, exclusive series for first year MBBS and for the students, those who are preparing for your NEET PG and your INI CET. So this session will be taken by Dr. Kohila ma'am, fantastic teacher for anatomy, who is taking a very good sessions, and lots of topics have been covered so far. And today we are going to have a brief discussion on neuroanatomy. Thank you so much, ma'am, for joining among your busy schedule. The session is over to you, ma'am.
A very good evening to one and all. Thank you, Raghu, for that warm introduction. Yes. Okay, guys, we have planned to have anatomy revision once in a month at least, right? Rapid revision of each topic region. Okay. So last month we saw on head and neck, and today we have planned like a 1 hour rapid revision of high yield points in neuroanatomy. Whenever we get to hear the term neuroanatomy itself, we get sort of a panic, right? Yeah. But if you understand that there's nothing much to fear about it, when you get to understand, master the concepts, solving the questions will become very easy. Trust me. Okay. So what is that we are going to see? The high yield points. Neuroanatomy book itself is going to be very small that you're going to cover for your NEET PG entrance examination, isn't it? So of those topics, the very important ones, okay? So in relation to development of the nervous system, the one that I'm telling you now is must know, okay? So the must know ones before you sit for any exam, okay, in neuroanatomy. So coming to the development of neurosystem, you're expected to know about the neural tube. The neural tube development, when does it close? What are the neural tube defects? Okay, you can get an image-based question on it. And then, of course, derivatives of neural crest cells. And in spinal cord, what they keep asking frequently every year is about the tracts. You know the name of the ascending tract, the descending tract. You're supposed to know the location of the tract and the arrangement of fibers in the tract. Okay, we have just questions on that. We'll be saying it and let's apply. And then brainstem, yeah, of course, what are the components of the brainstem? We have the midbrain, pons, and medulla from above below, isn't it? So the features that you see on the ventral surface and the dorsal surface, including the floor of the fourth ventricle, like everything is important for an image-based question. And then the syndromes, the brainstem syndromes. Can you tell me which of the syndrome they keep asking repeatedly? Yes, it's the Wallenberg syndrome, the lateral medullary syndrome. It keeps coming repeatedly. Okay. And cerebellum is very important. Everything about cerebellum. Okay. The lobes of cerebellum, the cortex of cerebellum, the deep cerebellar nuclei, its connections, lesions of cerebellum, everything is important. Of course, ventricles and CS of circulation, especially the lateral ventricle, fourth ventricle parts, you should be able to identify in an image. Cerebrum, of course, the sulci, gyri, functional area, homunculus, blood supply. Everything is important. White matter, yes, the three types of fibers, and among that, corpus callosum, and yes, you can tell me, internal capsule, very important clinically, isn't it? Basal ganglia, the components of the basal ganglia, you should be able to tell it, identify it in image, a horizontal section, a coronal section, whatever image given, you should be able to identify the components of it and lesions of basal ganglia. Finally, blood supply of brain. Okay, brain and spinal cord. So these are the high yield points which are expected to know before you sit for an exam in neuroanatomy. And as I told you, yes, at the beginning itself, I'll give you some one-liners in neuroanatomy. You can answer it with me. And then of the questions discussed, I put all the important image-based questions in neuroanatomy, like the supralateral surface, medial lateral surface, sagittal section, coronal section, all that. And then case scenarios, okay, which are very important. Are you with me? Can we start? Yes. Okay, you can keep answering in the comment box, right? So what are the Charcot's, what is called as the Charcot's artery of cerebral hemorrhage? Yes, it's a branch of the middle cerebral artery. To be very specific, yes, the lateral striate branch of middle cerebral artery. What do you mean by the term striate? So the branches of the middle cerebral artery, which are going to pierce the outer gray matter, inner white matter, and what is that in the inner core of white matter? The basal nuclei, the corpus striatum, all that. So these branches which are going to supply, yeah, those are called the striate branches. And the lateral striate branch of middle cerebral artery is called the Charcot's artery of cerebral hemorrhage. So whenever in an uncontrolled hypertensive patient, okay, so these are the arteries which are first to rupture. That's why it's called the Charcot's artery of cerebral hemorrhage. Coming to the second one, the recurrent artery of Hubner, that's a branch from the anterior cerebral artery, which is going to supply the anterior limb and part of the genu of the internal capsule. Why do you think it's called recurrent artery? Because it's going to have a curved course, okay, come back and then supply the anterior limb. And then, yes, who's going to tell me? Anterior choroid artery is a branch of, yes, internal carotid artery. Am I right? Posterior choroid artery is a branch of posterior cerebral artery, which is again a branch of basilar artery. Okay, so these terms keep confusing. Anterior choroid is a direct branch from the internal carotid. Posterior choroid from the posterior cerebral. And then you can get an image-based question where the pointer is on the lateral sulcus and they can, yeah, what are the contents present there? It's of course the middle cerebral artery. And what vein is that? The superficial middle cerebral vein. What is the other name for lateral sulcus? Guys, yeah, Sylvian sulcus. Okay, now few basic things that you have to understand in neuroanatomy to follow the lesion. You know, there are two cerebral hemispheres, right? The right and the left. So right has control over the opposite side of the body. So lesion of the right cerebral hemisphere, yes, the patient will present with features on which side of the body? Contralateral, isn't it? Cerebellum, it's exactly the reverse. The two cerebellar hemispheres have control over the same side of the body, isn't it? Okay. So any lesion of cerebellum, the patient is going to present with features of the lesion on the same side of the disease. Ipsilateral. Internal capsule, like I told you, internal capsule is very important. The arrangement of fibers in it, the blood supply of different parts of the internal capsule, right? Okay. So, and lesion to the right side internal capsule again, the patient will present with features on the contralateral side. And among the high yield topics, okay, coming to the tracts, posterior column, the dorsal column pathway, fasciculus gracilis, cuneatus, you know, a lesion involving this, okay. Yes, it's going to present, the patient is going to present with features, their symptoms on the same side. Okay, it's going to carry the sensation from the same side of the body. What about the spinothalamic tract? Yes. So what are the two spinothalamic tract, you know? Yeah, the lateral and the anterior spinothalamic tract, and both are crossed, isn't it? In the anterior white commissure they cross, right? Okay. So, and yeah, lesion of the spinothalamic tract, the patient will present with symptoms on the contralateral. Okay, contralateral. And coming to the corticospinal tract, yes, coming from the cortex, cerebral cortex to the anterior, to the spinal cord, isn't it? The crossed ones form the lateral corticospinal, and the uncrossed fibers, they descend as the anterior corticospinal, isn't it? So the cross fibers, where does the crossing occur? In the medulla, right? You call it as the pyramidal decussation or the motor decussation. So before crossing, yeah. So if there's going to be a lesion of the corticospinal tract before motor decussation, the patient is going to present with symptoms on the contralateral side. Okay, after the decussation, it's going to be on the ipsilateral side. So these are very, very, very important. The basic thing of neuroanatomy that you should know. Once you know, then you can solve the problems very easily. Okay. So which is on the contralateral, which is on the ipsilateral, you'll be able to pick out where the lesion is, which side the lesion is. Got it? Yeah. Coming to this point, the level of termination of the spinal cord in the adult, it corresponds to lower border of L1. And in children, you can tell me, it corresponds to the lower border of L3, isn't it? Yeah. So you have the spinal cord and the three meninges that are going to cover it. Yes, you have the spinal, pia mater that extends down as the phylum terminal. Then you have the arachnoid, and then outer to the arachnoid, you have the dura mater. So where does this dura mater, the arachnoid end? Yeah, they both fuse and they end at, yes, 2 level. Where is the subarachnoid space situated between the arachnoid and the pia, right? So that will also end at S2. Now, what is happening to the pia mater? It extends below the termination of the spinal cord, below the termination of the dura and the arachnoid, and fuses with the dorsal surface of the first coccygeal vertebra. How many coccygeal vertebrae are there? 3 to 4. Okay. So this phylum terminal, it goes down and fuses with the dorsal surface of the first coccygeal vertebra. And you can tell me, yes, what is the common site to introduce a needle to, yes, withdraw CSF from the subarachnoid space, which you call as the lumbar puncture? L3 to L4, well below the termination of the spinal cord. So these are the important landmarks you're expected to know. And easy this, yeah. So what is the vessel which is going to be involved in the extradural hemorrhage? Come on, you can enter your answer. Yes, extradural hemorrhage where the blood accumulates outside the dura. Middle meningeal vessels, isn't it? Right. Subdural hemorrhage where the blood accumulates between the dura and the arachnoid in the subarachnoid space. What is the main structure which is going to travel in the subdural space, having a long oblique course and which is susceptible for rupture? Yeah, the cerebral veins, right? The superior, the middle, and the inferior cerebral veins, especially the superior cerebral veins, which travel in the subdural space and terminates into the superior sagittal sinus, right? You have the superior sagittal sinus, the superior cerebral veins, they travel obliquely in the subdural space to reach the superior sagittal sinus, okay? So these veins, they can rupture leading to subdural hemorrhage. Subarachnoid hemorrhage normally involves is due to rupture of the berry aneurysm of circle of Willis. So the branches of the circle of Willis, which commonly can present with berry aneurysm is, yes, the posterior communicating artery, the anterior communicating artery, right? The anterior communicating artery is going to connect the anterior cerebral artery of both the sides, right? What is the posterior communicating artery connect? So you have the basilar artery dividing into posterior cerebral artery. Yes, so the posterior communicating artery is going to connect the internal carotid artery, the termination of the internal carotid artery with the posterior cerebral artery. So an aneurysm, a berry aneurysm of these, the circle of Willis is located in the subarachnoid space. A berry aneurysm of these vessels, okay, can in a hypertensive patient can rupture leading to subarachnoid hemorrhage. Right. Intraparenchymal hemorrhage, as I told you, is due to rupture of the striate branches. We started with one branch, right? Charcot's artery of cerebral hemorrhage, which is a branch of middle cerebral artery. So rupture of these striate branches can lead to intraparenchymal hemorrhage, right? So these are the ones which are definitely expected to know. Now, can we move on to the MCQs? Easy? Yeah. Yeah, can you read it for me? All the following are derivatives of neural crest cells except, yes, which is the right answer? Come on. So what are the derivatives of the neural crest? What is neural crest cells? So you know there is a trilaminar germ disc, right? Ectoderm, mesoderm, and endoderm. So in the midline, you have the notochord below the ectoderm. This notochord, it stimulates the overlying ectoderm to thicken to form the neural plate. This neural plate then converted into a neural groove, and the edges of the neural groove are thin, right? So once the neural tube from the neural plate, neural groove, and neural tube is formed, these thin edges called the neural crest, okay? These cells, they separate, they can migrate to the underlying mesoderm. They go in different direction, giving rise to different things, okay? So you should, why have I put this picture? Because you can get an image-based question, right? They've asked that, pointing out the image. So you should know where is the neural crest situated. The edges of the neural plate or the neural groove, yeah? It's called the neural crest. So this one, yeah, you should be able to identify it in the image. Okay. So what is it going to give rise to? As I told you, a variety of components. Okay, you remember it migrating to the pharyngeal arches, the pharyngeal arch syndromes, everything. Okay, so it's going to give rise to the bones of the face, the skull, the dermis of the face and the neck, and lot other structures which you can remember using this mnemonic. Yeah. So this picture gives you a story, right? I need not explain it. I'm going to the content, okay? So what are the derivatives of neural crystals? So in the heart, the neural crystals are going to give rise to the conotruncal septum, the conotruncal septum that separates the pulmonary trunk and the ascending aorta. And then it's going to give rise to the endocardial cushions. What are these endocardial cushions going to give rise to? The atrioventricular valves, the semilunar valves. So the neural crystals, they play an important role, right, in the development of the components of the heart. Yeah, coming to the next one, C. What are the cells which are going to come from the neural crest? So that's what I put this mnemonic poems, okay? Yeah, you can try recollecting and answering it. P stands for the parafollicular cells or the C cells of the thyroid gland, okay? O, what does the O stand for? Odontoblast, okay? Not the amyloblast, yes? And then enterochromaffin cells, enterochromaffin cells. M, you can put two things for M. Okay, one is the melanocytes, please remember, and the other is the cells of adrenal medulla. Okay, the adrenal medulla. And yes, S stands for the Schwann cells, the cells of the peripheral nervous system. Yeah, the Schwann cells, the satellite cells. Okay, the Schwann cells. Yes. H is done. C is done. G. What does the G stand for? Okay, you know the neural tube is going to give rise to the central nervous system, the brain and the spinal cord. The components of the peripheral nervous system, the autonomic nervous system, sympathetic, parasympathetic, that is going to come from the neural crystals. Okay, so the ganglia, G stands for ganglia. What ganglia? Sympathetic ganglia, parasympathetic ganglia, which you see in the wall of the viscera. Anything else? The cranial nerve ganglia. One more, the dorsal root ganglia. So whatever ganglia, it's all going to come from the neural crystals. So it's a very easy, interesting pictorial mnemonic to remember the derivatives of neural crystals. Okay, done. Coming to the next question. So what was the answer? Sorry for the previous one. Derivatives of the neural crystals are all except, yes, the amyloblast, they don't come from the neural crystals, but from the surface ectoderm. Now, coming to the second MCQ related to development, anencephaly. Okay, I've just put two questions in development. Yeah. Anencephaly occurs due to, yes. So I told you the neural tube development is important, right? We have seen neural plate, neural groove, and the neural folds. Okay. So when does the neural groove is going to approximate to form the neural tube? Yeah. So so this is the neural tube. The folds of it have to approximate to form the tube itself. Even once after the tube is formed, it's going to be open above and below, right? The lumen is going to communicate with the amniotic fluid. Okay, so when you button a shirt, you can like button it from up, down, or from the middle, right? So the closure of the neural tube, it begins somewhere in the middle. You want to know? Yeah, it begins in the cervical region, where you have the fourth or fifth cervical somite. Okay, and then it proceeds upwards from there and downwards from there. So which neuropore will be the first to close, the one which is above or the one which is below? It is in the cervical region, right? So logically it makes for the neuropore at the top, which is called the anterior or the cranial neuropore, which is going to close first, isn't it? Around day 25, around 18th to 20th somite stage. Okay. And yeah, since it started in the cervical region, it takes a little bit longer for the posterior or the caudal neuropore to close. Posterior or the caudal neuropore to close. Do you know what day it is? Day 27 or 28, certain textbooks give, right? And it corresponds to 25 somite stage. Okay, so this is very, 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 very important. Okay, these events, closure of the cranial neuropore, closure of the caudal neuropore, right? And the cranial neuropore is going to form the lamina. It represents the cranial end, the topmost end of the neural tube. Yeah, the neural tube is the one which is going to give rise to the forebrain, midbrain, hindbrain, and the spinal cord, isn't it? So what will happen if this topmost neuropore is not going to close? Yes, what will happen? The neural tube defects, the one, yeah? The part of the brain at the top end, the forebrain, right? It's not going to be formed, yeah? And it presents as a mass of brain tissue, and the overlying skull is also not developed. And what is this called? Yes, this congenital anomaly is called as anencephaly, which occurs due to failure of closure of cranial or the anterior neuropore, right? Okay. Now, a word about the glial cells, the neuroglial cells in the central nervous system, you know, right? Astrocytes, what is its function? The foot process of the astrocyte is going to be in contact with the blood vessel to form the blood-brain barrier. What is the function of oligodendrocytes? Myelination of the axons in CNS. Ependymal cells, they line the ventricle, help in the circulation, yes, of the CSF. Microglial cells are phagocytic in function. So of the four, which one is going to be derived from the mesoderm? Yes, microglia alone is going to be derived from the mesoderm. Right. Now coming to a question on spinal cord tracts. Easy. A patient with syphilis develops imbalance on walking with eyes closed and has to lift up foot and stamp on ground to walk. Yes, name the tract involved in this condition. Yes, you know what is this? Yeah, so he's having a difficulty with closed eyes, right? So it's all to do with proprioception. So of the tracts mentioned below, which are the ones which is concerned with, yes, proprioception here, dorsal column, only the dorsal column. The spinocerebellar tract is concerned, whatever reaching the cerebellum, yeah, that is unconscious proprioception. But syphilis, yes, spinocerebellar tract, where are they located? They're going to be located in the, yes, lateral white column, right? The lateral funiculus. Okay, the dorsal column is located in the dorsal funiculus. Okay, and syphilis. Okay, it's mentioned syphilis or the tabes dorsalis that typically involves the dorsal column. Yes, the dorsal column is involved in syphilis. Now, yes, who's going to tell me? What are the functions or the carried by this dorsal column pathway? Yes, fine touch or the discriminative touch, 2-point discrimination, proprioception, vibration, stereognosis, isn't it? So this we call it as a Romberg's test. You ask the patient to close his eyes and scan. He'll be swaying. Okay, I can't put a foot forward. And how to differentiate it from a posterior column lesion or cerebellar lesion? If it's going to be cerebellar lesion, so even with eyes open, there will be swaying of the trunk. Okay, ataxia will be present even with eyes open. Yes, okay, yeah. And in dorsal column, proprioception is lost. So the patient will present with swaying or like difficulty in keep putting his foot because the proprioception. What is proprioception? It's the sense of joint position. Okay, yeah. So in posterior column lesion, the patient will present with swaying only with eyes closed. Okay, and cerebellar lesion, please remember, there'll be swaying of the trunk. Ataxia will be present even with eyes open. That's the main difference that I want you to note. What are the other features of the dorsal column pathway? Yes. So where is the first order neuron? It's the ascending tract accepted. And we just now saw what are the features, the functions of the dorsal column. The other high yield points related to dorsal column is the first order neurons are situated in the dorsal root ganglia. Where is the second order neurons? In the nucleus, gracilis and cuneatus in the medulla, isn't it? So the axons coming from this nuclei, they form the internal arcuate fibers. The fibers of both the sides, they decussate, right? Sensory decussation. And they ascend up as medial lemniscus. And where does this medial lemniscus end? In which nuclei of the thalamus, right? In the ventro-posterolateral nucleus of the thalamus. From that, they project to the post-central gyrus. 3, 1, and 2. So lesion of the posterior column is usually on the ipsilateral side. So these are the things you are expected to know in relation to dorsal column pathway, right? So it's very, very important to know the name of the ascending, descending tract, their location in the spinal cord, right? So among the descending tract, you have to know about the lateral corticospinal tract, okay? The anterior corticospinal tract. Yeah, descending, the pyramidal tract. And among the ascending tract, definitely you should know about the fasciculus gracilis and cuneatus. Fasciculus gracilis is going to carry all these sensations from the lower limb and trunk, isn't it? Up to your T6, yeah. And upper part of the trunk and the upper limb is going to be carried by the fasciculus cuneatus. And the location of the spinocerebellar tract, anterior posterior spinocerebellar tract, the location of the spinothalamic tract. The location, their features, lesion, yeah. Not only that, okay. So this was a recently asked question in the NEET PG entrance examination. Sustained an injury in the dorsal cord and only the lateral part is injured. Okay, so you definitely know it's the dorsal column pathway. Now we have to figure out which part of the body is involved. So it's very, very essential to know the arrangement of fibers, okay? Arrangement of fibers in the important tract. Okay, so this is our dorsal column pathway, right? And you know, fasciculus gracilis is medial, fasciculus cuneatus is lateral. So here it's easy to figure out, right? Cuneatus is from the upper part of the body. So the lateral most will be the cervical. And the medial most is going to be the fasciculus gracilis, which is going to come from the lower limb. So the sacral segment will be more medial. So the arrangement of fibers from lateral to medial is going to be cervical, thoracic, lumbar, and sacral. Okay. And the other two tracts also, which you're supposed to know, is the corticospinal and the spinothalamic tract. Okay. So here in these two tracts, the arrangement of fibers from superficial to deep. So imagine a knife is going to be placed, okay? A knife is going to be placed here, which is going to cut the superficial fibers, right? So as you see here, that is going to involve the sacral segment. So patient will have features in the lower limb. Okay, so the arrangement of fibers in the spinothalamic tract from superficial to deep will be sacral, lumbar, thoracic, and cervical. Okay, it's somewhat similar for the corticospinal also. A knife on the superficial aspect will injure the sacral fibers. Sacral, lumbar, thoracic, and cervical. Superficial to deep. Okay, so here what will be the answer? Dorsal column, lateral most part, fasciculus cuneatus for the upper limb, isn't it? Okay, arm. So either it should be this or this. But you know, dorsal column pathway, first one liners even we saw, right? It's going to be ipsilateral. So undoubtedly the answer is ipsilateral arm. Yes, guys. Okay. So that is what you're so yeah. One more on the spinal cord. Yes, so it's given it's Brown-Sequard syndrome. You have to just find out which one is the wrong one, isn't it? So it's easy with a clue, even you can tell, right? So vibration, discriminative touch is a feature of the dorsal column, which is supposed to be on the ipsilateral, right? Pyramidal tract, yes, corticospinal tract. Yeah, once it reaches the spinal cord after crossing ipsilateral, so correct. Pain and temperature is carried by which tract? Lateral spinothalamic tract, isn't it? So that is supposed to carry fibers from the opposite side of the body. So the answer is this. It is supposed to be contralateral loss of pain and temperature. So most of the case scenarios will be this only, ipsilateral, contralateral, which part of the body. Okay. So these points you have to concentrate a little more. So hemisection was the other name for the Brown-Sequard syndrome. Hemisection of the spinal cord. Okay. So again, that will be involvement of the dorsal column pathway. Yes. Spinothalamic and the corticospinal, right? Lateral corticospinal. So as said earlier, dorsal column features will be on the ipsilateral side, spinothalamic contralateral, and this one will present with ipsilateral upper motor neuron type of spastic paralysis below the level of lesion. Okay, guys. So yes, that's about Brown-Sequard syndrome. Now help me to identify these spinal cord syndromes also. So where is the lesion here? In the anterior gray horn. Okay, so which disease affects the motor neurons in the anterior gray horn? Yes, poliomyelitis, right? So that will present with lower motor neuron features of palsy. Lower motor neuron, remember, lower motor neuron, lower, hypo. Okay, so it will present with hypotonia, hyporeflexia, flaccid paralysis, right? The muscle is not going to move at all. Okay, lower motor neuron and atrophy, denervation, atrophy, right? Babinski's will be negative, right? Coming to this one, yeah, what is here again? Here again, I accept it is anterior gray horn. Okay, but what is the difference between this picture and this picture? 1 and 2. This area, come on, see it with me. This area, what is it? That's the anterior commissure, isn't it? And what tract is going to cross over there? A spinothalamic tract. Can you understand the difference between figure A and B? Yes. So A is just only the motor neurons in the anterior gray horn. What is there in the figure 2? It's involving the anterior white commissure, where there's crossing of the spinothalamic tracts, which is going to receive the sensation from opposite side of the body. Okay, so there'll be contralateral. Or here it's in the commissure, right? It's going to be bilateral. Bilateral loss of pain and temperature. Yes. And this one I just put to explain the blood supply of spinal cord also. Okay, here as you see here, the anterior 2/3 of the spinal cord is going to be supplied by anterior spinal artery, which is a branch of vertebral artery. And the posterior one-third of the spinal cord is supplied by posterior spinal artery, which is again branch of the vertebral artery. Okay, so occlusion of the posterior spinal artery is called as the posterior cord syndrome, which, as you see here, involves the dorsal column of both the sides. So there'll be bilateral loss of posterior column sensation. But what will be preserved? Touch and pressure carried by the spinothalamic tract is going to be preserved. Coming to this one, yes, anterior two-thirds of the spinal cord, the major bulk of the spinal cord is supplied by anterior spinal artery, right? So occlusion of anterior spinal artery, that is going to produce the anterior cord syndrome. So there'll be bilateral, right? Bilateral features involving which tract? Okay, again, what is that? Spinothalamic tract will be involved. Spinocerebellar tracts will be involved. The corticospinal tract will be involved. Which one is spared? The posterior column sensations are spared. Okay. So we have just quickly rushed through spinal cord where we have concentrated on the tracts, right? The location of the tract, the function and lesion of the tract, ipsilateral or contralateral. Okay. And the arrangement of fibers in the tract, spinal cord syndromes. All right. Poliomyelitis. And then what is that? This is syringomyelia. Syringomyelia, a cavity lesion appearing in the central canal, encroaching the anterior gray horn and the anterior commissure. This is poliomyelitis, right? Anterior cord syndrome, posterior cord syndrome. Coming to the next important topic, the market cell inhibit which of the following cells? So what is this? They keep asking repeatedly in the NEET PG entrance examination. It's an histological image of the cerebellum cortex. Right. So what are these cells which are like nice? How do you see it? A single row, right? Single row of neatly arranged spaced cells. What are those cells in the cerebellum? The Purkinje cells, right? The Purkinje cells of the cerebellum. So the cerebellar cortex has three layers from outer to inner. Outer molecular layer, middle Purkinje layer, and the inner granule layer. The outer molecular layer has two cells, stellate cell and the basket cell. And the middle Purkinje layer, as the name itself, okay, you have a single row. This area I would like to highlight and show. A single row of large flask-shaped cells, the Purkinje cells. And then the inner granular layer. Why do you think it's called granular layer? Because it has lot of granule cells, right? Granule cells, small ones. And these Golgi cells, yeah. These are the Golgi cells. So totally you should know there are 5 cells in the cerebellar cortex. Of the 5 cells, only granule cell is excitatory. Okay, this they keep asking. Only granule cell is excitatory. All the other cells are going to be inhibitory. Okay. Yes. So this is what I told you. This is the outer molecular layer where you see only a lot of pink, right? Not only it should be either the dendrites of the Purkinje cells or the axons of the granule cells, basket cells, stellate cells. Okay, that's why a lot of pink. And then all these blue dots that you see here, right? All those tiny blue dots, that is the granule cells, the inner granular layer. Then where is this Purkinje layer? I'll zoom it for you. The tip of the green arrow, you can make out round once here. These are the Purkinje cells in the middle layer, neatly well spaced, arranged. Okay. And yeah, this you have seen the flower-shaped body, right? The dendrites are reaching the outer molecular layer. The axons will pass through the inner granular layer. Okay. The other thing they keep asking is about the afferents. The afferents to the cerebellum. Yeah. It comes from two, so they're divided into two types of fibers, climbing fibers and mossy fibers. Please remember those afferents which are coming from the olivary nucleus, accessory olivary nucleus called as the olivo-cerebellar fibers and the par-olivo-cerebellar fibers. Okay. Only these come under climbing fibers. All the other afferents to the cerebellum, right? The vestibulocerebellar, spinocerebellar, the pontocerebellar, everything is grouped as the mossy fibers. Now, what is the difference between these climbing fibers and mossy fibers? So these climbing fibers, the olivocerebellar fibers, right? It's going to come and synapse with one single Purkinje cell. They make monosynaptic contact with the Purkinje cell. Whereas the mossy fibers, through the granule and Golgi cells, they can act over many Purkinje cells, okay, through the granule cells. It makes polysynaptic contact with the Purkinje cell, okay. Climbing fibers, 1:1 ratio. Here it is like more than one mossy fiber can stimulate can act over thousands of Purkinje cells, right? Now, the other thing, the afferents are coming, climbing and mossy fiber, they are going to synapse over the Purkinje cell. The axons of the Purkinje cell, they form the only efferent leaving the cerebellar cortex. Where does these axons go? These axons, they go and end over the deep cerebellar nuclei. And remember, the Purkinje cell axons are inhibitory. They've asked it, okay? The axons of the Purkinje cells are inhibitory to the deep cerebellar nuclei. There's another image-based question. The nucleus of the cerebellum. Cerebellum, like cerebrum, it has an outer gray matter, inner white matter, and within the core of white matter, again, you get the nuclei. And the arrangement of nuclei from lateral to medial is DEGF. This large, yes, a crumbled bag appearance, the large and the lateralmost nucleus, that's the dentate nucleus. The nucleus of the neocerebellum, very important. All the important efferents of the cerebellum is going to come from this dentatorubral, dentatothalamic tracts, all that, right? And the second one, right? This is the emboliform nucleus. And the third one, that's the globose nuclei. These together are called interpositus. The nucleus of the paleocerebellum, which has control over the limbs. Okay. And this one, the one which is medial most, closer to the midline, on either side of the midline, that's the fastigial nuclei. Since it is in closer proximity to the roof of the fourth ventricle, it is also called the roof nuclei. This fastigial nuclei is the nucleus of the archicerebellum, which has control over the trunk of the body. Okay, lesion of it can lead to truncal ataxia. Right? Okay. Yes. So this is all you should know about the cerebellar cortex. Another important thing, yes, expected from you, the cerebellar peduncles. Middle cerebellar peduncle transmits. Yes, you know the answer. The middle cerebellar peduncle is going to connect what and what? It connects the pons with the cerebellum, right? What is its other name? It's called the brachium pontus. Okay, yeah. And the answer for this question will be pontocerebellar fibers. Let's check the other options. Posterior spinocerebellar tract. How does it reach the cerebellum? It reaches through the inferior cerebellar peduncle. What about the anterior spinocerebellar and the tectospinal tract? They reach the cerebellum through the superior cerebellar peduncle, right? So the afferents and efferents of these cerebellar peduncles are must know. So in an image-based question also, you should be able to identify the 3 cerebellar peduncles, okay? So, you know, this is the cerebellum, right? Yes? Okay. Here, this one coming from above, right? This one, this is your superior cerebellar peduncle, right? Superior cerebellar peduncle is going to connect the midbrain with the cerebellum. So this is the region of the midbrain. So coming from that, going downwards, that will be the superior cerebellar peduncle. Now this one here coming from below, that's from the medulla, right? Going towards the cerebellum. That's the middle cerebellar peduncle, connecting the medulla with the cerebellum. And this one here, right, in the pons, connecting the pons to the cerebellum, this is the middle cerebellar peduncle. Okay, and here, you can make out the middle cerebellar peduncle here also. This is your pons, right? This is pons, this is medulla. So this picture I've just put to show you the middle cerebellar peduncle. The superior and inferior cerebellar peduncle, they are more visible in the dorsal view. This is the ventral view where you can make out easily the middle cerebellar peduncle connecting the pons with the cerebellum, right? So yeah, the superior cerebellar peduncle is also called the brachium conjunctiva. Middle cerebellar peduncle, brachium pontus. The other name for inferior cerebellar peduncle is restiform body. Okay. Now, yeah, you can just take a screenshot of it. Okay, it's an easy mnemonic to remember the afferents passing through the inferior cerebellar peduncle. Yeah, normally we call it as popcorn. I just put it as pop car. Okay, of these you have to remember posterior spinocerebellar. Okay, others all you can just make a note of it. And middle cerebellar peduncle, please remember, there are no efferents, It's only the afferents. It's only from the pons to the cerebellum, the pontocerebellar fibers, right? And superior cerebellar peduncle also, I've just put a mnemonic for you to remember easily. Yes, you can make a note of it. And of these, the important one is this one. Anterior spinocerebellar reaches the cerebellum through the superior cerebellar peduncle. Posterior spinocerebellar reaches through the inferior cerebellar peduncle. And remember, the superior cerebellar peduncle main thing is the efferents. The efferents of the neocerebellum is going to leave the cerebellum mainly through the superior cerebellar peduncle. What is the nucleus of the neocerebellum? Dentate nucleus, I told you, right? Okay, so the dentatothalamic, the dentatorubral. Yeah. Coming to the next question, we are moving on to cerebrum. Yes. During treatment of meningioma, the left paracentral lobule was injured. It will lead to paresis of? Yes. So where is this paracentral lobule? Is it here? So what is this surface? What is that you're seeing here? You see the cerebellum. You see the cerebrum. Show me where is the paracentral lobule. Yes. Where is the central sulcus here? Yeah, this is your central sulcus. This is the posterior ramus of the lateral sulcus. Here, that should be the parieto-occipital sulcus. Right, this is the posterior part of the calcarine sulcus. Now, where is our paracentral lobule? So, you're not seeing it here, right? I will show it to the medial surface. Now, here, can you tell me which is the paracentral lobule? Okay, you can make it the corpus callosum here. This is the rostrum. This is the genu, right? Genu, the trunk, and the splenium of corpus callosum. So it will help you to identify anterior and posterior, right? Now, this one is the central sulcus. This gyri which surrounds it is the paracentral lobule, isn't it? So what is this part? This is your medial frontal gyrus. And this one is the parieto-occipital sulcus. This one, it's the calcarine sulcus. Now tell me, what is this gyri? That's the cuneus. Between the parieto-occipital and the calcarine is the cuneus gyrus. And this one is the precuneus. Okay. Now, what are we worried about? We are worried about the paracentral lobule. Okay. So the question is, right? Paresis of. Okay. So it's the left paracentral lobule. What did we learn? If it's the left, the patient is going to present over the right. So it should be either this or this. Now coming, which part of the body is represented in the paracentral lobule? Yes, come on, tell me. Yeah. So this part this is your supralateral surface. This is the medial surface where you see the paracentral lobule. Which part of the body is represented here? The lower part of the body, the lower limbs, the perineal area. Okay, the perianal region. Yeah, perineum. Yes, the anal region, all that is represented. And hence, lesion of the paracentral lobule is going to present with features over the right leg and perineum. Patient presenting with hemiparesis. Both, it has both motor and sensory cortex. Precentral and postcentral gyrus is there. Okay, so patient will present with weakness, okay, hemiparesis or hemiplegia, and sensory problems also, especially urinary incontinence. Okay, so that's about the paracentral lobule. Now, this one, what is this cross section of? It's the, come on, you can see a cavity here in this like little posterior. That's the cerebral aqueduct. So which part of the brain the cerebral aqueduct is going to traverse? It's the midbrain. You see a cross section of the midbrain, right? So this is the crus cerebri of the midbrain. What is this dark area here behind the crus cerebri? That's the substantia nigra. Yes, which is going to secrete the dopamine. And deficiency of, yes, dopamine, that's going to lead to which disease? Parkinsonism, right? Parkinsonism. Yeah. And what are the features of Parkinsonism? Yes, you get the tremors. What type of tremor? Tremors which are present at rest, isn't it? Resting tremors. Yeah, pill rolling movement, rigidity, lead pipe rigidity, cogwheel rigidity, akinesia, mask-like facies, stiff shuffling gaits, stoop posture. All these are features of Parkinsonism, right? Coming to the other options, can you tell me where do you get to see intentional tremor? In the cerebellar lesions. Yes, hemibalismus and chorea. Yes. So resting tremor, yeah, when the patient is at rest, typically seen in lesion of the substantia nigra, Parkinsonism. Okay, I think I put a GIF here. Yes. So you see the intentional tremor when the person wants to perform an act, tremor appears. That's very typical of cerebellar lesion. Okay, that's a very, very important clue for you to differentiate in a case scenario. Right? These pictures I took from Wikipedia only, right? So ABC, athetosis, balismus, and chorea. All these are involuntary movements, right? Next point, you should know which part of the body is affected in each thing, right? So athetosis is going to typically involve the distal extremities, right? And balismus or hemibalismus, that involves the proximal extremities, which means that the girdles, okay, the shoulder girdle or the pelvic girdle, the trunk, right? Violent involuntary movements of these regions. And chorea can like actually involve any part of the body. It could be the limbs, it could be the face, it could be the tongue, okay? So jerky movements of these parts. Coming to the third point that you should know about it, lesion, okay? Due to which lesion these things happen? Chorea occurs due to lesion of the caudate nucleus. Easy to remember, CC. Hemibalismus or balismus occurs due to lesion of the, yes, subthalamic nucleus, which is again part of your basal ganglia. And athetosis due to involvement of the corpus striatum, yes, basal ganglia, globus pallidus. Okay, lesion of all that can lead to, right? Now, yes. So here, which of the following is not a component of the syndrome related to the vessel indicated? Tell me which vessel is marked by those yellow arrows. So this, you want me to take a different color? I'll take a green or something. So this is your vertebral artery, right? You can see the basilar artery. What is this branch from the vertebral artery? The yellow is pointing to a branch coming from the vertebral artery, producing some syndrome. Yes, those yellow arrows are the pointing at the large tortuous branch from vertebral artery, which is the postero-inferior cerebellar artery. What is the syndrome related to postero-inferior cerebellar artery? The lateral medullary syndrome, or also called as the Wallenberg syndrome. Yes. So it's easy here. You know which is medulla, right? So this is the medulla. And what are the structures in the medulla that you see on either side of the midline? You get to see the pyramid. What lies underneath it? The corticospinal tract. This is olive, right? What lies underneath? The olivary nucleus, inferior olivary nucleus. Between the two, this nerve that's emerging out, that's the 12th. So the pica syndrome, or which is called as the lateral medullary syndrome, or the Wallenberg syndrome. As the name indicates, lateral medulla, isn't it? So this 12th nerve, which lies on either side of the midline, is not going to be involved, right? Now, behind the olive, you get to see 3 nerves coming out, right? Can you tell me? This is 9, this is 10, this is the 11. So what is the nucleus common to these 3 nerves? Yes, nucleus ambiguous, right? Nucleus ambiguous. The nucleus for the 10th nerve, you also have the dorsal nucleus of vagus, right? Yeah. And what lies lateral here? Yes, we just now saw, right? This is your nucleus gracilis, nucleus cuneatus. This is the inferior cerebellar peduncle, right? And above that, you get to see another elevation here, which is called as the tubercinarium. What lies underneath the tubercinarium? The spinal nucleus of the trigeminal nerve, isn't it? And one more here, the floor of the 4th ventricle, this is called the superior vestibular area. This is inferior vestibular area, which is going to have the vestibular nuclei. I've not put you the cross section of the medulla. I'm just trying to explain what are the components which are involved in lateral medullary syndrome, just using an external feature picture, right? So it's the nucleus ambiguous. And then, yeah, you get to see the vestibular nucleus is there. You see the spinal nucleus of trigeminal nerve, right? And then, which is not seen here, but one just closer to the spinal nucleus of the trigeminal nerve laterally in the medulla, the lateral spinothalamic tract. And yes, of course, the inferior cerebellar peduncle. So these are the 5 structures which are involved in the lateral medullary syndrome, right? So this posterolateral zone of medulla, the posterolateral zone of medulla, which is going to be supplied by postero-inferior cerebellar artery, right? Occlusion of which will lead to lateral medullary syndrome or the Wallenberg syndrome. So involvement of the nucleus ambiguous, which is going to give rise to the cranial nerves, right? The special visceral efferent column, 9, 10, 11, right? That will cause ipsilateral paralysis of the muscles of soft palate, pharynx, larynx, right? Okay. The second one, yeah, spinal nucleus of the trigeminal nerve, that will lead to ipsilateral loss of sensation, right? Spinal nucleus is concerned with pain and temperature from the face, right? And any other nucleus we saw? Vestibular nuclei, right? That will give rise to giddiness. It's related to posture, equilibrium, right? So giddiness on the ipsilateral side. And then any tract? The lateral spinothalamic tract. Yes, as we saw, contralateral loss of pain and temperature from which part of the body? From the trunks and limbs. Okay, face is spinal nucleus of trigeminal nerve. And lastly, the inferior cerebellar peduncle leading to ataxia. Okay, a Wallenberg syndrome is very frequently asked. You should know the artery involved, the components present in the posterolateral zone, and the features of its lesion. Okay. Yeah. So what is the answer here? This is right. Paralysis of muscles of palate. Ipsilateral from the face is right. Contralateral of position and vibration sense, that is that this is not present, right? Yeah, this is also present because of the spinothalamic tract. Coming to the next MCQ, here is easy. So what they're telling is that the features were present over the face, no weakness in the limbs. Tongue was involved, uvula was involved. So which part of the following options has been involved in this case scenario, right? So the patient is presenting with features which are confined to the face, the head and neck, right? So this you should know the arrangement of fibers in the internal capsule. Yes. So what are the parts of the internal capsule that you see here? This is the anterior limb. The one circled here is the genu. This is the posterior limb. And here you're supposed to see the retrolentiform part. And here will be the sublentiform part. Okay. Yes. So the corticospinal fibers, which are going to supply the head and neck, is going to be situated in the genu, right? Corticonuclear fibers for the head and neck. So lesion of the genu will primarily involve the head and neck, the face, right? And the posterior limb has the corticospinal, that's the pyramidal tract, right? The corticospinal fibers which are going to supply the limbs, the upper limb, the trunk, the lower limb. Also, the posterior limb is traversed by the extrapyramidal fibers. Okay. The other important thing, the retrolentiform part is traversed by the optic radiation and the sublentiform part by the auditory radiation. Okay. So please, this is very, very important. Okay. So this should help you to pick out the correct choice in the given question. Yes. Now, identify the artery, which is not a branch of the pointed structure. So what is the artery that is shown here? Yes, it's easy, right? That's the internal carotid artery. So, you know, the internal carotid artery, it lies in the cavernous sinus, right? So it lies in the cavernous sinus, it pierces the roof, and then it gives rise to branches, right? So it gives rise to the superior hypophyseal artery. Yes, the next branch will be ophthalmic artery, right? It gives two terminal branches. The smallest of which goes front here. This one, that's the anterior cerebral artery. And the larger terminal branch is the middle cerebral artery, which turns laterally. This is your middle cerebral. This is the anterior cerebral. Okay. So 1, 2, 3, 4. And yes, it gives rise to the anterior choroid artery. And one more, posterior communicating artery, right? So the artery which is not a branch of the pointed structure is posterior choroid, which is coming from the posterior cerebral. The posterior cerebral is in turn a branch of the basilar artery. So there are 3 cerebral artery, anterior, middle, and posterior, of which posterior cerebral is coming from basilar artery, the vertebral system. Okay. Anterior and middle cerebral is coming from internal carotid. Right. I want to use the same picture to show something else. So I'll erase it. Right. So as you see here, you can make out the internal carotid, right? And then anterior cerebral here, middle cerebral artery here. This is your posterior cerebral artery, right, from the basilar artery. So all these 3 arteries, they lie in the inferior surface of the cerebrum. okay, in the interpeduncular fossa. So that point you should be able to appreciate it, right? And here, right, you can read the case like, he had developed some symptoms, okay, and CT is showing ischemia in the territory of left middle cerebral artery, okay. So which of the following areas of the brain would not have shown ischemic changes? Which of the following area of the brain is not supplied or is not affected by an occlusion of middle cerebral artery? 2 minutes, we can go through the cerebral blood supply of the cerebrum. As I told you, all the three arteries, you can see it on the inferior surface. You'll be able to identify it, right? You won't have a problem. The anterior cerebral artery, the middle cerebral artery is going here, and the posterior cerebral artery. Now, the three arteries you're going to identify in the next picture also. So this is the medial surface of the cerebrum, isn't it? Now, can you show me the arteries here? So this is your corpus callosum. You can see the genu here running parallel to the corpus callosum. That's the anterior cerebral artery. This is your splenium, right? Just below the splenium, that's the posterior cerebral artery. Now, this is the lateral sulcus, right? We saw a one-liner in the beginning. The content of the lateral sulcus. This is the middle cerebral artery, right? The functional areas which are going to be supplied by the anterior cerebral artery, we had a case scenario, right? Yes, the paracentral lobule on the medial surface. And then not only that, this anterior cerebral artery, it gives branches that supplies the, yes, supralateral surface, the upper part. So it will include, what is this area? The anterior most part of the frontal lobe, the prefrontal cortex, right? And then upper part of your precentral gyrus, postcentral gyrus, and what is this area? The upper part of the parietal lobe, the superior parietal lobule. All these are going to be supplied by the anterior cerebral artery. So occlusion of anterior cerebral artery, what do you expect? Yeah, prefrontal cortex is going to affect the personality of an individual, right? Your premotor cortex, the primary motor cortex, the premotor cortex, right? 4 and 6, upper part, right? Postcentral gyrus 3, 1, 2, the upper part. Superior parietal lobule 5 and 7, which is concerned with stereognosis, right? And which part of the body is going to be represented in this part? It's going to mainly involve the, yes, the upper limb and the trunk. The lower limb, okay, yeah. Paracentral lobule, we saw it as the lower limb, right? Okay, both motor and sensory component. So that's about the anterior cerebral artery. Now, coming to the middle cerebral artery, yes, the middle cerebral artery is going to supply, yes, this area, majority of the supralateral surface that of course has the primary frontal eye field is there, premotor cortex, primary motor cortex, 3, 1, 2, right? 1 and 2 in the postcentral gyrus. And your motor speech area, the Broca's area 45, 44, the primary auditory cortex, and then the sensory speech area 40 and 13 and Wernicke's area. Okay, so the middle cerebral artery mainly supplies these functional area. Occlusion of the middle cerebral artery, if it is on a dominant hemisphere, can produce a global aphasia, right? And coming lastly to the posterior cerebral artery, it's mainly concerned with the blood supply to the visual cortex. So occlusion of the middle cerebral artery is not going to affect the visual cortex. Okay, 17, 18, 19. Yeah, just 2 more questions. Yeah, no, 5 more minutes. We'll finish off. During lumbar puncture, after piercing which structure, the needle will enter the epidural space, right? Any idea what is the answer? So where are these ligaments situated? We'll just see and come back to the question. So you know this is the spinous process, right? Connecting the spinous process, this will be the interspinous ligament. Okay. And here, just above the spine, tip of the spinous process, this will be the supraspinous ligament. Right? This is your lamina on the inner aspect of the lamina, connecting the laminas. Okay. Here will be the ligamentum flavum. This is supposed to be the connecting the anterior surface of the body of all the vertebra, anterior longitudinal ligament. There's one more thing I would like to mention here. The posterior surface of the body, they are connected by the posterior longitudinal ligament. Right? So if I'm going to put a needle, it has to pass through this supraspinous ligament. Yes. And then interspinous ligament, ligamentum flavum to enter the vertebral canal. And then within that, you have the epidural space, dura, subdural space, arachnoid, subarachnoid space. Once you enter the subarachnoid space, you enter the CSF, right? So you can remember this mnemonic. Okay, the structure is pierced by the needle during a lumbar puncture. For epidural space, you stop outside the dura. For lumbar puncture, to get the CSF, you have to reach the subarachnoid space. So it will be skin, superficial fascia, supraspinous, interspinous, ligamentum flavum. You shouldn't confuse with ligamentum flavum and posterior longitudinal ligament. Okay, yeah. And then the dura mater, extradural space, dura mater, subdural space, arachnoid. Right? Okay. This is one more question. Just identify this section is very, very important, right? So what you see here is the corpus callosum. This is supposed to be the genu of the corpus callosum. So the fibers which pass from the genu of the corpus callosum anteriorly, this A is the forceps minor. Okay. And you know, corpus callosum is an example of commissural, right? Commissural fiber that is going to connect the identical areas of the right and left cerebral hemispheres crossing the midline. Okay, so from the genu going forward, what is marked A is forceps minor, commissural fiber, right? And second, B, that's internal capsule. Just now we saw, right? It's coming from the cortical to the subcortical area. It is an example of projection fiber. C, what is C? C is fornix, right? That's the fornix. Fornix is, of course, a projection fiber. It is also an association fiber. Fornix is projecting from, where? From the mammillary body. From the hippocampus, right? It's coming from the hippocampus. It is going to the mammillary body in the hypothalamus. Hypothalamus is part of the diencephalon. So it's going from telencephalon to diencephalon. And that's an example of projection fiber. What is D again? D is coming from the splenium of the corpus callosum going backwards. That is forceps major. Okay, so they have asked, identify the correctly matched pair. A is forceps minor. B, from the splenium backwards, forceps major. This is internal capsule. This one I'll erase and show you here. Yes, so this is the corpus callosum. This is the fornix. Okay. You have the septum pellucidum, right? The septum pellucidum that separates the lateral ventricle of both the sides. So this septum pellucidum above is attached to the undersurface of corpus callosum and below to the fornix, right? I think this is the last MCQ, okay? So the following, this was again a recent NEET PG INICT exam question. And the following structure projects into which thalamic nucleus? So what is pointed out here? That's the mammillary body, right? The mammillary body, which is again part of the hypothalamus. So what is coming to this? Again, that's the fornix, right? And from where is it coming? From the hippocampus. It's part of your Pappas circuit, right? And from the mammillary body, where is it going? It's going to the anterior, right? Yeah, so this was a repeat question. You should remember that the mammal, this is your thalamic region, right? It goes to the anterior nucleus of the thalamus. The high yield points of the thalamic nuclei, Alan, I'll just share it with you. So you have in the ventral tire, right? You have the ventro-postromedial and ventro-postrolateral. Okay, ventral tire is divided into ventral anterior, ventral intermediate or ventrolateral, and posteriorly, ventral posterior is divided into VPM, ventropostromedial, ventropostrolateral. I'm just going to talk about these three. 1 minute and we'll wind up. So the ventropostromedial, that will receive the solitariothalamic tract. What is that? Which is projecting from the nucleus tractus solitarius, and the trigeminothalamic tract from the nucleus of the trigeminal nerve, right? So VPM. VPL, the afferents are coming from the two lemniscus. Spinal lemniscus. What are the other lemniscus you know? Which reach the thalamus, medial lemniscus. Okay, yeah. And ventrolateral, the afferents are coming from cerebellum. Ventral anterior, the afferents are coming from the subthalamic nucleus. The substantia nigra and the subthalamic nucleus, all that. Okay, where is it going to project to? So thalamus, you know, that's the final relay station for all the sensory impulses. And from here, it's going to project to the the cerebral cortex, right? Okay. So VPM and VPL, they project to 3, 1, and 2. Post-central gyrus. Ventrolateral, which is receiving from the cerebellum, right? That is going to project to 4. The primary motor cortex and the premotor also. Right? Ventral anterior is going to project to 6 and 8. Right? Yes. Okay, guys. So this is what I wanted to quickly revise with you for today's session. Hope it was useful. Do send us your feedback and any corrective measures, right? Okay. Thank you. We'll wind up. Any doubt you can enter in the comment section.
Thank you, ma'am. Thank you so much. I hope you will post this video or attach your press. Yes, of course, the video will be there in the YouTube itself, so you can watch it even after the session get in. And those who have missed today's session also, you can just rewind it and you can just watch it again. So we will make sure that from next month onwards, it is made in the weekends. I got few feedback that the weekends we want. So we will try to make it weekend, because both ways everyone has to be free. So we will make sure that it will be convenient for you all. Thank you so much, ma'am, once again for joining with us today. It was a great again listening to your session. Thank you, ma'am. So I hope we will have a next session in the upcoming month soon. Thank you, ma'am.
Thank you, Raghu. Thanks. Thank you, guys. Good night.
Hello.